So Dr. Kamlesh, I think we're good to go. Let's begin.
Yeah, switching on the Facebook Live as well. Yeah, good to go.
So should I speak?
Start.
Good evening. Myself Kausik Mollik. I am actually, this is our first webinar. Dr. Kamlesh Jain is our speaker. We have Ruchi ma'am, Rishi Raj. Okay. I want to speak something, Dr. Ruchi ma'am. Ruchi ma'am, you need to unmute.
Good evening, everyone. It's a great day. First webinar of IAP West Bengal branch along with IAPWC, and I am very happy. And thanks to invite me. The topic taken up by our esteemed speaker, Dr. Kamlesh Jain, is very important and you know, in a way different also from the other webinars going on. We'll be discussing about the injuries, lumbar strain in the fast bowlers. मैं थोड़ा सा टॉपिक से अलग हटके सारे हमारे पार्टिसिपेंट्स को ये बोलना चाहती हूँ कि कोविड-19 पीरियड इतना डिफिकल्ट पीरियड है सबके लिए, स्पेशली फाइनेंशियली, फिजिकली, मेंटली, लेकिन अगर हम इसमें एक ब्लेसिंग इन डिस्गाइज देखें तो इतने अच्छे रिसोर्स पर्सन, इतने अच्छे वेबिनार्स ऑर्गेनाइज्ड वे में जो आपके सामने हमारी टेक्निकल टीम ऑफ IAP इंडिया, आई वुड लाइक टू थैंक डॉक्टर सुमंत सर. Thank you sir for beautifully, you know, starting the things. And जिस तरीके से एजुकेशन को फिजियोथेरेपिस्ट के पास लाया जा रहा है इस समय में जब सभी लोग किसी ना किसी समस्या के साथ जूझ रहे हैं, इट इज कमेंडेबल, इट इज इनक्रेडिबल. और कोविड-19 में मेरे सभी फिजियोथेरेपिस्ट के लिए मेरा एक मैसेज है कि take physiotherapy as an emergency service. इस समय देश रिकॉग्नाइज कर रहा है, गवर्नमेंट रिकॉग्नाइज कर रही है. We are essential in all the stages of corona. चाहे वो प्रिवेंटिव लेवल हो, चाहे वो अवेयरनेस लेवल हो, चाहे वो जब पेशेंट सिक है और पेशेंट हॉस्पिटल में है तो हमारे कार्डियो पल्मोनरी फिजियोथेरेपिस्ट का रोल, या पोस्ट क्वारंटीन उनकी मोबिलिटी, उनकी फ्लेक्सिबिलिटी, उनको साइकोलॉजिकल काउंसलिंग, उनको डिफरेंट स्टेजेस से निकाल के लाने का रोल फिजियोथेरेपिस्ट को आज मिला है. और उसको बेहतरीन तरीके से यूज कीजिए, अपग्रेड कीजिए अपनी नॉलेज को, डिसअपॉइंट मत होइए. वेरी सून लाइक अब हमने ये जो चैनल हमारा स्टार्ट हुआ है IAP इंडिया का यूट्यूब पर, एंड इन 10 days वी हैव गॉट मोर देन 3000 सब्सक्राइबर्स. इतना यूथ सपोर्ट फ्रेटर्निटी ने दिया है, थैंक यू सो मच. एंड आई एम कीपिंग माय फिंगर्स क्रॉस, जैसे कि अब इन दिस पीरियड द होल वर्ल्ड हैज रिकॉग्नाइज्ड द पोटेंशियल ऑफ इंडिया. हमें WHO में इतना लॉन्ग ड्यू एक्नॉलेजमेंट मिल रहा है इंडिया को. सो आई एम जस्ट कीपिंग माय फिंगर्स क्रॉस कि very soon we will be coming to an international platform. WCPT में it's in the process, very soon we are joining, and we hope कि हम लोग इन सब चीजों के द्वारा अपने आप को इंटरनेशनली प्लेटफॉर्म पर रख सकें, साउंडली रख सकें. इंडियन एसोसिएशन ऑफ फिजियोथेरेपिस्ट की तरफ से आई वुड लाइक टू थैंक ऑल द पार्टिसिपेंट्स एंड स्पेशली आवर रिसोर्स पर्सन टू गिव द क्वालिटी इंफॉर्मेशन. आई एम होपिंग that this webinar will be the most wonderful webinar of the series of IAP Bengal. Thank you for patience listening. Thank you.
Thank you, Dr. Ruchi. We are very thankful to you, Dr. Sanjeev Jha sir, to give us the freedom and to be able to create this platform. So our request, before even we start, we would want that each and every physiotherapy student and physiotherapist of our country should really come together and show their unity, or by joining this, momentum with respect to joining or subscribing Indian Association of Physiotherapists IAP India YouTube channel, and also IAP the Indian Association of Physiotherapists Facebook page. I think both are very empirical at this moment in terms of showing our unity and to be able to really convey that, we are one and we all are fighting together for one common cause. And we are glad today that we have Dr. Kamlesh Jain on behalf of IAP West Bengal. So I congratulate, and without wasting time, I would now request Dr. Kamlesh to kindly begin with his presentation. Over to you, sir.
Can I start? Hello, I'm audible?
Yes.
Yeah. So before I start my presentation, I want to thank the Indian Association of Physiotherapists West Bengal branch for inviting me for this webinar and present my topic on lumbar stress injuries in fast bowlers. So quickly, without wasting time, I'll just share my screen. So is my screen visible? Kaushik, Rishi?
Yeah, visible.
Yes, visible.
Yeah.
Yes.
So good evening again, guys. The topic of present, please.
Yeah, I would request if you can be a little close to your mouthpiece because your voice is a little suppressed.
Sorry. Is that okay now?
Better.
Yeah. Okay.
Thank you.
So good evening, physio colleagues. My presentation this Sunday evening is on lumbar stress injuries in fast bowlers. So it is a term that is used to describe radiologically confirmed lesion in the posterior vertebral arch. So the key word to understand here is radiologically confirmed lesions. So we cannot make the diagnosis of a lumbar stress injury purely by our clinical examination. We need a radiological support to come to a diagnosis of lumbar stress injury. The other key word we need to understand is posterior vertebral arch. So initially, probably 15 years before, lumbar stress injuries were diagnosed more in the pars intra-articularis. But now, due to the advancements in radiology, lumbar stress injuries are also diagnosed in the lamina as well as the pedicle. So this injury has a wide spectrum. So you can have an acute bone stress reaction, or you can have chronic defects. So in the case of an acute bone stress reaction, again, you can split it into pre-spondylolytic bone stress reaction, and a stress fracture. So if you look at pre-spondylolytic bone stress, we will not find any clinical symptoms in the athlete. It is more changes seen in the MRI. Now, this could be due to an incidental finding or routine MRI examination. In the case of a stress reaction, we will elicit symptoms clinically, as well as we have some radiological support supporting our clinical examination. In the case of a stress fracture, we will elicit symptoms. We will have bone marrow edema on the MRI, accompanied by a definite cortical breach, a fracture line. So if you come into chronic defects, these are probably the lesions which were probably undiagnosed, or they are not treated properly, or the athlete getting into sport quickly, and he developed a non-union. So these non-united fractures are generally seen on a CT scan, where the fracture line is clearly evident, and we can see chronic changes on the investigation. So if you come to the risk factors, the first one is age, next one is bowling action, and the third one is workload. So these three are the primary risk factors with a lumbar stress injury. So if we have to look at age first, so this condition is extremely common in 16 to 22 years of age. One reason what research is showing is that in this age group, the intervertebral disc is relatively elastic when compared to intervertebral disc in adults. So as a result of this, there could be a lot of forces which is dissipated into the posterior vertebral arch over a period of time, and then that could result in a lumbar stress injury. The second reason, as we all know, is skeletal immaturity. The bone ossification is going on. And in that process, when a lot of load is loaded into the lumbar spine, the bones can't take up that load, and they react in the form of an edema or a stress fracture. Research is also showing that in case of long bones like the femur, the ossification is generally complete at about 20 or 22 years of age. But in the lumbar spine, the ossification process can go up to the age of 25. Growth cartilage versus adult cartilage. So in the younger population, as we're talking in the age of 16 to 22, the cartilage is not as strong and is not as resilient as the adult cartilage. As a result of this, a lot of stresses can again be laid into the posterior vertebral arch, resulting in a lumbar stress injury.
Dr. I
yeah.
would like to interrupt you. Your voice is breaking and ain't clear. So I would request if you can really keep the mouthpiece just in front of you, because while on trial, your voice was pretty clear. A lot of participants have, complained that they are unable to hear you.
Is that okay now?
This is much better. Thank you so much.
Okay, sorry. Do you want me to start from the beginning or shall I just continue?
I think it's good. We can go ahead.
Okay, cool. Thank you. So the second major risk factor for a lumbar spine injury is the bowling action. So if you look at the components of a fast bowler, there are three major components. One is the run-up, the next one is the delivery stride, and the third one is the follow-through. So our main area of concentration now is going to be in this delivery stride. So if you look at fast bowling, there are three main types of action. This is a side-on action. This is an open-chested action, and these two are the mixed action. In between these two, you can have a semi-open action as well. So if we have to first talk about the side-on action. So in the case of a side-on action, the back foot of the fast bowler is parallel to the crease, and the contralateral upper body is just inside the face of the bowler. So again, I repeat, the back foot is parallel to the crease, and the face is just behind or slightly outside the contralateral upper body. So this is in the case of a sidearm bowling action. If you go into an open-chested or a front-on bowling action, in this case, the back foot is perpendicular to the crease, and the contralateral upper body is outside the fast bowler's face. So again, I repeat, in this case, the back foot is perpendicular to the crease, and the contralateral the contralateral shoulder is outside the bowler's arm. Okay, so these two are the side-on and open-chested action. Now coming to the mixed bowling action. So in this case, what happens is you can have a mixture of these two actions. Like in this, you can clearly see the back foot is an open-chested position, whereas the upper body is in a side-on position. So clearly we can see here the back foot is perpendicular to the crease, and the upper body, the orientation of the upper body is that a side-on action. So as a result of this, I can clearly see here the force vector goes in this direction, and in this case, the force vector goes in this direction. As a result of this, when both the feet are in contact with the ground, this can cause a lot of rotation through the lumbar spine, a lot of shearing forces happening to the lumbar spine, and when this force is placed over a period of time, it can result in a lumbar stress injury. Again, action D. In this case, again, we can see the foot orientation is that of a side-on action, where the foot is parallel to the crease, and the upper body is in the open-chested position. So again, we can clearly see the force vectors moving in this direction and in this direction. So when this front leg is placed and both the feet are in contact with the ground, there can be a lot of rotational forces going to the lumbar spine, going through the lumbar spine, and when this happens over a period of time, then the athletes are subjected to a lumbar stress injury. There are a lot of biomechanical aspects related to the bowling action, but I think this is the most basic thing that we need to understand. The front foot impact, this is again a major issue which we need to understand. So in this case, you can see that the knee is completely extended. Now, in this case, what would happen is a lot of ground reaction force would be transmitted through the hip and subsequently to the lumbar spine. So, in the event that the fast bowler is lacking strength or stability in his hip, then a lot of force is transmitted through the lumbar spine and can sort of result in a lumbar stress injury. But the advantage of having this action is that a lot of forces can be generated, and the bowler can bowl at a pretty good speed. Now, if the landing leg is bent, a lot of forces are actually absorbed at the knee, and less force go onto the hip and subsequently to the back. But the problem with this is it can have an impact on the speed at which the bowler bowls. So it is a trade-off which the bowler needs to be aware of. If he bowls with the knee straight, then he can bowl quick, but there is obviously an increased risk of a lumbar stress injury. If he bowls with a knee bent, then he's compromising on his pace, but then there is a relatively lower risk of a lumbar stress injury. So the third factor is the workload. So a sudden increase in workload can predispose to a lumbar stress injury. Now, as we are going through this unprecedented times of Corona and COVID situation, most of our cricketers have just been taking rest. They have been indoors. They haven't done much of bowling and cricket related work. So when they get back to field again, it is extremely important that their return to match fitness is in a very and a gradual return to play. Bowlers just can't go out there and bowl straight away. That the risk of an injury is going to be extremely high. Again, we look at acute and chronic workload ratio spikes. You need to build up your workloads gradually so that there's a good chronic build up to the workload. A lot of research has been done on workload now, and Professor Tim Gabbard is an expert in this, and you can definitely look into his work on workload. The next important thing that we need to know is whenever there is an increased episode of workload, the highest chances of developing a lumbar stress injury is 3 to 4 weeks after that. For example, if the bowler has an increased episode of workload today, then probably 3 to 4 weeks after today is the highest risk time for a lumbar stress injury. So this was a study done by Hulin et al. In 2013. So they found that when a bowler bowls more than 50 test match, when a fast bowler bowls more than 50 overs in a test match, 2 weeks after that, there's a 9% chance that he can get a lumbar stress injury. Post 3 weeks, there's a 13% chance, and around 4 weeks, there's a 16% chance of the bowler sustaining a lumbar stress injury. Interestingly, they also found out that if a bowler bowls more than 30 overs in the second innings, if a fast bowler bowls more than 30 overs in the second innings, probably after 4 weeks, there's a good 28% chance of them sustaining a lumbar stress injury. So we looked at 3 major risk factors: age, bowling action, and workload. But more often than not, it is a combination of 3 factors. We cannot single out one factor which could lead to the injury. It is a combination of all 3 factors. So a younger fast bowler, say an 18-year-old fast bowler with a mixed bowling action and a sudden acute spike in his bowling workload, will be at a considerably higher risk of sustaining a lumbar stress injury than say a 28-year-old bowler who's got a decent action and his workload are reasonably good. So the other risk factors that we need to take into account is if the bowler has got a lumbar lordosis, morphological changes like decreased interfacet distance, increase in the pedicle length. Also, we need to take into account that if there is a low longitudinal arches of the foot, then the chances of a lumbar stress injury increases because the shock absorption capacity of the ankle and the foot is diminished. Now, this study in 2008 found that if the ipsilateral hip internal rotation range is greater than degrees. So for a right arm fast bowler, if his right hip internal rotation range is greater than 40 degrees, then there is a chance of a lumbar stress injury. They couldn't find any particular reason why this could lead to a lumbar stress injury, but one probable hypothesis was that this could be due to impaired gluteal medius activity. The other interesting finding in this study was that if the contralateral ankle dorsiflexion range is less than 12 centimeters, then again it's a significant risk for a lumbar stress injury. This study also found out that if the contralateral ankle dorsiflexion range is more than 14 centimeters, then the lumbar stress injuries risk significantly decreases. So one reason why this could lead to a lumbar stress injury is that when the ankle lands, there's a lot of ground reaction force that the ankle is sustained, and if the ankle is not in a position to sort of move as it wants to more than 14 seconds, then the lot of forces is attenuated, and as a result of that, the proximal part of the kinetic chain, your hips and the back, can take a lot of load, and that can result in a lumbar stress injury. So the pathogenesis of this condition is there's repetitive load laid on the lumbar stress as a fast bowler bowls. So say probably if they bowl say 300 balls in a week, as a result of loading over a period of time, the stress is so much that it exceeds the normal bone strain threshold, and then it can react. Also a combination of movements. So fast bowling, as we know, is a combination of movements. You can have extension, you can have a side flexion, you can have a rotation component. So all these three components involved together can cause a lot of shearing forces on the lumbar spine, as a result of which you can have a lumbar stress injury. This is extremely important. High ground force. So when a fast bowler's the front foot ankle lands, it takes about 7 to 10 times of the body weight. So for example, if a fast bowler is say 70 kgs, he's loading his ankle close to 600 kgs each time he lands. And imagine he does that day in and day out. You can imagine the load that goes through that ankle. That's why, as we discussed in the previous slide, the ankle range of motion is extremely important, so that the proximal part of the kinetic chain is preserved. So most of the lumbar stress injuries happen at the L5 level. This is probably due to the change in curvature in the spinal curvature as it transits from the lumbar to the sacral spine. So if you look at the clinical presentation, the first thing that we need to be careful is early morning stiffness, as with all inflammatory pathology. This is something we need to be extremely careful. And if a young fast bowler would come and tell you, I have got early morning, which is consistent, then I think we need to be extremely careful with that. If that stiffness is not taken care of properly, then it can progress to pain. So subjective, it's generally mostly on the non-bowling side. So for a right-arm fast bowler, a lumbar stress injury would generally start on the left side of his lumbar spine. More often than not, it is gradual onset where there is load built over a period of time, and generally you will have a history of change in training. So probably they're trying to work on the bowling action, or there has been a sudden spike in the number of balls they're bowling, or there has been a change in their gym program. So all those factors need to be taken into account. We will have bowlers telling, I was feeling stiff in the morning, then it got better. Then again, I came to the ground, I finished my warm-ups, I felt great. I could bowl without any discomfort. And then they will notice that after the body cools down, again the stiffness begins. So this injury generally follows a crescendo pattern of pain, where the pain intensity increases gradually. So initially it will be after the activity, and then it will progress at the end of bowling, then it will start in the middle of the bowling, and then it gets to a stage where the bowler is unable to bowl. So if you look objectively, generally the athlete will have pain on extension, a quadrant, and one leg hyperextension, which is the stock test. They'll have tenderness on palpation, but again, this is a very unreliable clinical tool. We can't completely go by the tenderness component. This pain after the initial pattern is mechanical in nature, in the sense that it aggravates by activity and it is relieved by rest. Occasionally, you can have radicular symptoms, pain radiating to the buttock area and the posterior thigh. So this was a pain grading scale followed in spondylolysis by Gregory et al. In their study in English fast bowlers. So that's as per their gradings, a grade 1 is if the bowler has pain after bowling. A grade 2 is during bowling, but doesn't impair performance. A grade 3 is during bowling, but it severely impairs performance. And then a grade 4 pain is when it prevents the bowler from bowling. Okay, so one like hyperextension test. So this is otherwise called as a stock test. So probably 15 years back, this test was a pathognomic for a lumbar stress injury. So if this test was positive, most of the clinicians would think that there's a good chance that that athlete has got a lumbar stress injury. But this study 6 by Masci and et al. Showed they actually compared the findings of this study and MRI, and what they found was this test has actually got a low sensitivity as well as specificity in the diagnosis of an active lumbar spondylolysis. and that this should not be relied to exclude the diagnosis. So this study can give us a false positive. So in this case, if the pathology is not present, but it shows positive on our testing, the reason could be that when you're doing the one leg hyperextension test, it could be stressing the facet joints, or it could be stressing the muscles or other structures. So it is extremely difficult to isolate if the pain that the athlete complains is because of some pathology at the pars or the pedicle or the lamina or the facets or the other structures. We could have a false negative where actually the pathology is present, but the test gives a negative result to us. Now, this is possibly if the lesions are at the higher lumbar level. So one the athlete would probably be hinging at that L5 level. And if the pathology is say L1, L2, this test could actually not elicit it. So it can give false negative results as well, which we need to be careful. So the important message that we need to understand is we cannot clearly go only by clinical examination. As I had mentioned in my first slide, we need radiological support to come to a diagnosis of a lumbar stress injury. So radiology, I think if there's one condition in sports where we need a radiological support, it is a stress injury. We need to coordinate with a radiologist and a sports medicine specialist, give them an history about what the athlete is exactly feeling, and then they will do the required radiological testing. So radiology helps us to identify the exact site, whether the injury is in the pedicle or is it in the lamina or is it in the pars. It helps us to identify the extent of injury. As I said earlier, fracture, or is it a stress reaction, or is it a chronic defect? It helps us to identify the nature of injury, whether there is any associated disky issue, or if there's a spondylolisthesis component, and other information. So again, establish the stage of bone continuum. As I said, extremely important for us to know at what stage the athlete is. Is it in a stress reaction stage, or is it in a stress fracture stage, or is it a chronic lesion? Determine prognosis. So our prognosis will be determined by what we find in the radiological finding. A stress reaction will probably heal earlier than a stress fracture. A pre-spondylolytic stress reaction will heal earlier than a stress reaction. So once we get to know our exact diagnosis, properly correlating our clinical findings as well as radiological findings, then we'll be in a better position to determine the prognosis for that athlete. Extremely critical and identify the subclinical cases. Now, subclinical cases are where we cannot elicit clinically, but we can see changes radiologically. This is probably an incidental finding. You actually send the athlete to for a scan to rule out some other issue, say a facet joint issue or a disky issue, and he actually ended up having bone marrow edema. And so in those sort of cases, that is a subclinical finding, and they're actually extremely useful in the sense that if you find it at that early stage, then we can help the athlete get on the field as soon as possible. So radiological options we have is X-ray, MRI, and CT. Obviously, the radiologists are the specialists in this, but I think as physios, we need to know some basic findings which we can see on the scans, so that we can sort of have a better understanding of the conditions. I think it is extremely critical that we give a good history about that condition to the radiologist. Tell them exactly what you're thinking, so that they can plan for the radiological evaluation accordingly. So, for example, in an MRI, you have a lot of sequences: T1, T2, proton density, fat suppressed. If we can give a background about what we are thinking clinically, then the radiological evaluation can be planned better, and then we can come to a collaborative decision. So in the case of an X-ray, I don't think so we'll find much changes in the early stage, unless or until it is a big massive fracture. We need to understand the orientation of this Scotty dog, which we'll do in the next slides. So MRI, as recent studies are finding, is that it is extremely sensitive to bone marrow edema. So MRI can easily pick bone marrow edema. Therefore, this is our first choice of investigation. CT generally done after the MRI, and CT helps us to find the exact site and the extent of injury. So if you look at an X-ray, this is the lateral view of the lumbar spine, and this is the oblique view of the lumbar spine. So we can clearly see the difference in the lateral and the oblique view. The oblique view gives us a better orientation of that Scotty dog appearance, which I was talking in the previous slide. So if we need to understand this Scotty dog, this is a good schematic representation. We can clearly see the nose represents the transverse process of the vertebra. The eye is the pedicle. The ear is a superior articulating process. The neck is the pars intraarticularis. The body is formed by the lamina, and then the forefoot by the inferior articulating process. And then you have the tail, which forms the superior articular process of the opposite side, and then the hindfoot, which forms the inferior articulating process of the opposite side. So just one more X-ray where I thought I'll give you some more orientation on how we can sort of correlate the Scotty dog and the parts of the vertebra, because I think this is going to be extremely important when we look into X-rays for our stress fracture diagnosis. So yeah, this is the one. So this is the normal Scotty dog appearance, where you can see that the bone intact. Whereas in the segment above, we can clearly see a cortical breach here. So this is a fracture. This is probably a fresh fracture of the pars interarticularis. Again, here we can see the segment above, everything is fine. Whereas you can see a cortical breach here, and then we can definitely see some sort of artifact here. So this could probably be a old healing fracture, or a fracture which is still healing. So again, just to give a recap, generally it's better that we go for an oblique view rather than a lateral view. As the Scotty dog is the orientation of the Scotty dog is better in the oblique view. We can clearly see the intact structures here in this X-ray, whereas you can clearly see a defect here on this X-ray on the neck of the Scotty dog, which is pars interarticularis. So the MRI, this is a sagittal view of the MRI. Yes, we are not experts in this. The radiologists are experts in this. I think it's a good opportunity for us to know exactly what the radiologists are finding in the investigations. So as I said earlier, MRI is extremely sensitive to bone marrow edema. We can clearly see this high signal intensity here. So what the radiologist will do is, once they find in which segment there's a high signal intensity, they will do a CT scan of that particular segment, and then find out the extent and site of injury. In this MRI, we can clearly see a cortical breach here. You can see in this segment there's proper continuity of the posterior arch, whereas in this we can clearly see a cortical breach. Again, in this MRI, as I said, it is extremely sensitive to bone marrow edema. So we can clearly, this is probably a T2 where we can see fluid here as dark white patches. So again, once the radiologist finds there's signal changes at this level, then they will do a CT of this segment and try and investigate it further. So if you look at CT scans, this is an axial view and this is a sagittal view. Just to give you an orientation, this is the body of the vertebrae, the pedicle transverse process. You have the lamina. This is the pars intraarticularis. This is the spinous process, and this is probably a mid-sagittal view of the CT scan. So again, CT, you can clearly see here there's a cortical breach here in the pars intraarticularis on the right side. We can see a bilateral fracture here. Again, we can clearly visualize the fracture lines in this as the bilateral fracture. In this segment, again, we can see a cortical breach here at the pars intraarticularis level. You can always compare it with the levels above. The same findings we can see here. So this study by Milson et al. In 2004 looked at, I think, about 10 bowlers. They were getting them scanned at various intervals and sort of tried to correlate the clinical findings along with radiological investigations. So if you see in subject A, so they got scans done at 6 months post-injury, 8 months post-injury, and 15 months post-injury. So if you see in subject A, that doesn't seem to be much of progress in terms of the fracture line on the CT scan. So this athlete would probably end up with surgery if the radionucleotide doesn't show a hotspot. Whereas we can clearly see a fracture line here in the right pedicle, a bit of and then after 15 months of the injury, we can see a reasonable healing here. So probably this athlete has responded well to conservative management, and this athlete has not responded as well as expected. So in the event that the fracture line doesn't show signs of healing, then we get a nuclear medicine scan. In this case, it's a SPECT CT scan. So we can clearly see these hotspots. So if you find a hotspot, then there's an indication that there's osteoblastic activity still happening. There's more potential for healing still. So probably in the athlete which we saw in the previous slide, who didn't have much of healing on the CT, if we find the hotspot, then we would probably wait because we know that there's potential healing still possible, and try and wait and watch. However, if we don't find any hotspots on the SPECT CT, then there's an indication that there's no chance of potential healing, and if the athlete is still symptomatic, then they would probably be subject to surgery. So this is just an X-ray of a surgical management. I can clearly see the screw fixation here at the pars intraarticularis, area. So if we try to correlate the clinical features and the investigations, so in the pre-spondylolytic stage, as I said earlier, you won't have any clinical features. You will find bone marrow edema on the MRI. You won't have any cortical breach on the CT. In the case of a stress reaction, you will have signs clinically. You will have bone marrow edema on the MR, but again, you won't have any cortical breach on the CT. In the case of a stress reaction, there will be clinical features. You will have changes on the MRI, and again, but you will find a cortical breach on the CT scan. In the case of chronic non-united fractures, sometimes they can be symptomatic, sometimes they can be asymptomatic. We won't find much on the MRI because this is not an acute injury, and you'll definitely have a cortical breach in the case on the CT. So the sequence, how we go about is that we'll first look for the clinical presentation, look for that early morning stiffness, get the basic blood testing done, like the vitamin D, calcium, routine blood testing done, which can influence bone activity. Get an X-ray done, but generally an X-ray will not give us much information. So get an MRI done. If you don't find bone marrow edema on the MRI, then I don't think so there's any acute activity happening. But if the MRI shows a bone marrow edema, then I think it's a good idea to get the CT scan done to check if there's any cortical breach or if there's any fracture. So, and then we commence our rehab program based on what we find on the investigations. If there's no improvement as per our plan, then we probably need to repeat the scan, also get the SPECT CT scan to check if there's any hotspots, and then we decide on the further course of action. So what's the importance of radiology in this condition? One is that, as I said, it is extremely critical to find these subclinical cases, and this can be only found on MRI. So if we find this, then we are definitely helping the player in terms of him not missing a major chunk of the season. Monitor progress through regular scans. So once diagnosed, say a stress fracture or a stress reaction, we can get scans done at regular intervals, say 6 weeks, 4 weeks, 8 weeks, and then are progressing radiologically as well. The prognosis will be based on radiological findings on what we find. Say whether we find a stress reaction, whether we find a stress fracture. Based on this, our prognosis can be made. So I think it's extremely important that we have a good rapport with the radiologist, give them a background of what you are thinking based on the history and the clinical examination, and then the radiologist can give us their feedback on what they find in the scans, and then a collaborative decision can be made. So our assessment plan, obviously, subjective history, extremely critical, looking out for that early morning stiffness, stiffness after bowling, stiffness the next day morning, try and get as much as information as possible from the athlete. Objective examination, as we discussed, the athlete will have pain on extension, quadrant, stock test, but it's not completely reliable again. Then you go for radiological, and then we come to a diagnosis. We try and correlate the subjective, objective radiological examination, and then we come to a diagnosis on whether it is a stress reaction or a stress fracture. So management of this condition, the timeframes will be different on where the athlete is, whether he's in a pre-spondylolytic stage, which is subclinical, whether it's a stress reaction, whether it's a stress fracture, or whether it's a chronic non-united stress fracture. Generally, the stress reactions will heal quicker than a stress fracture, but in some cases, it can prolong as well. So guidelines for management, we can probably divide this into three stages. The first one is the fracture healing stage. The second one is the protective loading stage, and the third one is transition to return to full function and sport. So I'm not going to go into the details of the treatment in full detail, because it's going to take a lot of time. So I'm just going to give guidelines on how we do the athlete. So in the healing stage, first priority is to protect the fracture healing site and prevent any further aggravation. So if it is a stress reaction, we want to prevent a stress fracture. If we find a stress fracture, then we want to try and promote bone healing and avoid a non-union. Try and stop all activities that could load the posterior vertebral arch. So if it's a severe stress fracture, then we might even we will have to avoid all axial and extension load for the athlete. Try and promote only pain-free activities. You can just do some basic core stability stuff. If the athlete has gone any impairments in terms of, say, thoracic rotation restriction, hip mobility restriction, ankle lunge wall is less, so we can try and work on all those components. But we don't want to do anything which loads the posterior vertebral arch and then impairs the healing. Again, we need to monitor early morning stiffness. Is the athlete getting better each day, each week? So the early morning stiffness. The next phase is the protective reloading phase, where we start gradual loading, then we progress into functional training phase, and then we prepare the athlete for resume to form fast bowling. So initially, we would start with basic body weight exercises. Even open chain exercises are great. Once the athlete is comfortable, then we would start loading them in a single plane. Probably even doing a single leg body weight exercises is a great idea. Once the athlete is comfortable with all this, then we can progress them to component loading exercises. We can get them brisk walking, get some axial loading going, use the alter G treadmill, get them running in the swimming pool, and then gradually progress them into jogging. So once the athlete is comfortable with all these, they're comfortable with brisk walking, they're able to take decent load in the gym, the early morning stiffness is getting better. Then once they have established a decent strength base, then we can subject them into plyometrics and power-based exercises. So the key with plyometric and power-based exercises is just not about generating that force. The athlete needs to have a good technique when they're doing this exercises, so that the forces can be absorbed as well. And then we slowly progress into field drills, into cricket specific drills. So the key we need to understand here is it is a criteria-based progression. It is not a time-based progression. It is not that, okay, we have diagnosed him with the stress reaction. It's 4 weeks now. Let's progress him now. It doesn't happen that way. We need to make sure that the athlete has fulfilled all the criteria in the previous stage before we progress them on to the next stage. So what are the criteria we are looking? Clinically, is the athlete better? Are the symptoms getting better? Is the early morning stiffness getting better? Is the point provocative tests which were giving him discomfort before, are they better now? Radiologically, are the blood results improving? Review scans showing that the edema has come down? Are the review scans showing that the fracture site is healing? And then we need to coordinate with our SNCs as well. Is the athlete getting more resilient in the gym? Are they able to tolerate more load? So based on all these factors, only then we will progress the athlete to the next stage. So from the healing stage, when we progress the athlete to the loading stage, we need to make sure that the athlete has ticked all these boxes. From the loading stage, when we progress again to the sports specific stage, we need to make sure that the athlete has ticked all these boxes. So again, I repeat, it's not a time-based progression, it is a criteria-based progression. So return to full function and sport. Has the athlete completed the entire rehab program? Is he radiologically clear? Is he able to do all the field drills and the cricket specific drills, all the exercises in the gym pain free, and he's not sore after sessions? Has he built up enough workload getting into a match situation? Bowling in nets is different, and bowling in a game is completely different. So does the athlete have enough workload to participate in a game? So this is generally a rehab graph. So this is extremely important for rehabbing someone with the stress injury, where the athlete is going to spend a lot of time in rehab. So this is an ideal sort of curve with the time on x-axis, the recovery on y-axis. This is the injured athlete, and the athlete expects to progress and improve every single day. and sort of get into that match fitness. But what really happens in rehab is you will have ups and downs. There are days when the athlete will feel great. He will be able to do all the exercise in the gym easily. There are days when he will wake up sore and he might not be able to sort of do whatever is expected of him. So the key is we need to be aware of this. I think in the first session when we sit with the athlete, we need to make the athlete aware that you will have ups and downs, but eventually you will get to this point B when again you're playing matches again. So return to play for a player, he wants to return to bowling and play cricket in the shortest possible time. So for the player, it is a goal focus. For a coach, he wants his player to play in the shortest possible time, as well as be able to perform at a pre-injury level. Whereas for a physio, we want the athlete to play as in the shortest possible time. We want the athlete to perform pre-injury levels, and at the same time, we want to prevent a recurrence and associated injury. So an associated injury here could be an athlete of recovering from a stress fracture coming on playing, and again, sort of having a side strain or a hip injury. So for a player, it is a goal focus. For a coach, it's a performance focus. Whereas for a physio, it is an outcome focus. So return to play clinical decision criteria. A lot of factors before we give the green signal to go and play. So age and type of injury. So if you look at stress fractures, probably a younger athlete will take a longer time to recover than an older athlete. Has the athlete is he clinically and radiologically clear? Has he done the entire rehab program? Has he done the entire conditioning program that the SNC gave him? Is he able to do all the field drills? Is he able to bowl as he was bowling before? Has he built up enough workload that sort of challenges his body to go and bowl in a match situation? So all these factors have to be taken into account. And then finally, the most important factor is the player psychology. Is he psychologically ready to go and play again? So initially there will be a lot of apprehension, but I think as the athlete bowls, as he plays more and more, I think that apprehension gets better. So injury recurrence. So in spite of having done everything, we will be faced with the situation where the injury has reoccurred. What could be the possible reasons for that? The first could be underestimated the injury severity. So probably the athlete had a stress fracture and we diagnosed it as a stress reaction. The injury location was not properly defined. Sort of any associated injury, probably the athlete has some disc issue as well, which was not properly diagnosed. The athlete did not complete his rehab program fully, or he did not complete his SNC program fully, or his load was not properly managed, and he got into a game situation too soon, and that could be one reason for the injury recurrence. Pressure from the coach, family, officials. There could be a big tournament, there could be a World Cup coming, and the athlete doesn't want to miss out opportunity. So the athlete sort of pushes himself too much too soon, and there could be an injury relapse. So the prognosis of this condition, as I said, the age, the younger the athlete, the more time he will take to recover. The extent of injury, if the fracture is only on one side, they'll probably recover quicker than the fracture on bilaterally. So the level and part involved. So generally, studies are showing that the closer it is to L5, the more time it takes to take to heal. And in terms of the part involved, the closer it is to the vertebral body, the less time it takes to heal. So all these factors need to be taken into consideration before we give an initial prognosis of the condition to the player, to the coaching staff, to the management, and all the stakeholders concerned. So strategies for prevention. I don't think so we can prevent an injury, but we can try and do everything to minimize for an injury. So identify high-risk athlete. If you're working with under 16, under 19 fast bowlers, I think those are our high-risk athlete, and we need to constantly monitor them. I mean, they might just casually tell us, I feel stiffness on my back as I wake every morning. I think that is something which we need to be extremely careful and make sure that we are constantly monitoring them. Risk factors, again, this bowling action, we need to coordinate with the coaches. If we find that there's something wrong with their bowling technique, it is extremely important that we coordinate with the coaches and get that sorted. What we have found out is that players with stress fractures and stress reactions, they complete a rehab program, they do their gym sessions, they become extremely strong and they become extremely resilient. But if there's a faulty bowling technique, they will again break down in say 3 to 6 months. So sorting out the bowling action is extremely important. Earlier you do this, the better. Probably if the bowling action is identified as a risky bowling action in the younger days, say under 16, under 17s, then I think that's probably the best time to try and make those minor changes as much as possible. Because once the bowler is sort of crossed age 23, 24, they've already played a lot of cricket, and then it would be very difficult for us to make those changes. Monitor workload, extremely important. We don't want any acute spikes in workload, and we want to make sure that there's a good chronic workload built up. Sorry, I think not able to. 1 second. Sumant?
Yes, sir.
Yeah, I'm not able to think my screen.
You
1
just
second.
click over your screen.
1 second.
Then please start again.
Yeah. Robust athlete. I think once we have rehabbed the athlete, once the athlete has returned to sport again, it is extremely important that we do a constant maintenance work. We want to make sure that the athlete is strong and resilient, extremely strong in their lower bodies, especially because those are their shock absorbers. And if the shock absorbers are strong, then there's less load which goes onto the back. So we want to make sure that at no point in time the athlete compromises on their strength, on their mobility, and all the components of fitness, so that in the longer run we can try and prevent a lumbar stress injury. So these are some of the references that I had used for my presentation. Just to quickly wind up, this is a cricket-specific injury course that we are planning to conduct. If anybody is interested, please feel free to contact this number. So Kaushik, Sumant, Rishi.
Yes.
Yeah. Hi, Kaushik. So this is I just did my presentation. If there's any questions from the audience side, please let me know and we can discuss that.
Only 3 questions I get.
Yeah, please tell me, Kaushik.
Can I share my screen?
Yes, please.
Yes, sir, you can share.
No, I can't.
Or if you can just tell me the questions
Kamlesh,
orally, I
sir,
can.
You have to stop your screen.
Okay, I need to close my screen, is it?
Yes.
Okay,
Yes.
I'll do that. Yeah. Thank you. Is that okay?
Yeah.
Okay.
So what is the reason for diabetic pain after 4 weeks? I think this is an excellent question. So if you look at that research article, they found out that the chances of a lumbar stress injury was significantly higher at 4 weeks post-injury, and they could not find any sort of specific concrete reason why this was happening at 4 weeks. The only reason they could sort of come up is that in the first few days after that acute spike in workload, the immature part of the lumbar spine was getting stressed, and the mature strong part was in a position to sort of take that load. But as the load kept building again and again during that 3-4 week period, that was the time where the mature part of the bone was also getting loaded, and then it got to a stage where the lumbar spine couldn't take the stress, and then eventually the athlete had symptoms and the athlete broke down. Again, they couldn't find any specific reason, but this was one reason which they were speculating in that journal, in that article. Yeah. Next question. My question is, player having lumbar strain during cricket match, is there any taping techniques or physios? Okay. So if it's a lumbar strain, yes, you can have a lot of taping. But if there's a lumbar stress, injury, I don't think so. Taping is going to help because the pathology is that severe. I don't think so. The athlete can take that much of load. So if it's a lumbar stress injury, the athlete has to be off cricket, off fast bowling. Make sure they do their rehab. Make sure they get stronger again. And if there are any other components which need to be worked on in terms of their bowling actions, in terms of their workload, that need to be taken care of. If it's a lumbar strain, yes, we have various taping options. So we can do a rigid taping, we can do dynamic taping. But again, we need to look at what possibly could contribute to that lumbar strain. It can be a rotation, restriction in thoracic spine rotation. It could be because the hips are not moving properly and they are sort of straining the lumbar vertebrae. Lumbar strain, yes, we can definitely manage with taping and physio, but a lumbar stress injury needs time off cricket. What fitness tests are to help players are fit or not? Okay, so we do a pre-participation screening for all our players. So that is mostly physio oriented, where we look at range of motion, muscle strength, previous injury. We try and get as much as information as possible from the players in terms of their previous injury, and then we try and make a rehab program. And then the SNC and the physio coordinate and conduct a series of tests for the players. So it can be some testing in the gym in terms of 1 RM vertical jump test. It could be field test like looking at double leg hops, single leg hops. It could be a 20-meter test. It could be a runner 3 test. It could be a yo-yo test, sprint repeat test. So there's a series of tests that are conducted pre-season. And then the readings are recorded. In the event that an athlete gets injured in the middle of a series, then we want to make sure that the athlete is again sort of fulfills the criteria what he had done pre-season. So a lot of tests are done pre-season, and we try and replicate that in the event of an injury to clear the athlete.
Next question, which fitness test we are using in cricket to help players to?
Yeah, that's what I just talked about, Kaushik. Yeah.
How to monitor workload in state level?
Okay, so if you look at Tim Gabbett's paper, so you have various apps also now, which the athlete can log in and they can put the workload on a daily basis, what they are doing in terms of number of balls bowled, in terms of RP that was in the gym, into how many minutes they are done, and then the app monitors the workload, and then if there is an acute spike in workload, it will give you a notification to the coach, the physio, the SNC. And then you sort of know that workload, and we need to be careful and taper off his workload. So generally, the formula used is your RPE into the number of minutes. So that forms the workload for that session. So each and every session's workload is recorded, and then we have the weekly workload. So when we get into week 4, we can look into the acute chronic ratio workload. So for week 4, if you look at the acute chronic ratio workload, it will be the average of week 4 divided by the workload ratio of week 1, 2, and 3, the average of that. And that ratio has to be between 0.8 and 1.3, which is considered as the sweet spot. If that ratio goes above 1.3, then there's obviously an indication that there's a high workload and could possibly be a precursor to injury. Interestingly, it also shows that if that ratio is less than 0.8, then it is an indication that the athlete is not loading enough, and that could also be to injury. I think if you can have this paper is open access. If you can just have a look on workload management by Tim Gabbett, it will give you a comprehensive idea on how we can manage workload.
Next question: every time hyperextension of knee leads to lumbar instability?
I don't think so. Every time it leads to a lumbar instability. So that could be one contributing factor. Obviously, a lot of bowlers bowl with hyperextension knee because it helps them to get that extra zip when they are bowling. But if the athlete is not strong in his hips, in his glutes, if the back is not strong, if the core is not strong, then there's a small chance that it is one of the contributing factors. It is not the only contributing factors. It is one of the contributing factors for a lumbar stress injury.
Is there any specific rehab program to decrease the increase, like Santa Monica for ACL?
Sorry, can you just slide on, Kaushik, please?
Is there any specific rehab program to decrease the incident like Santa Monica for ACL?
I'm not sure how ACL has come into the picture here.
Don't think so.
Yeah. So
Next question.
yeah.
Sir, can you please?
Yeah.
Sir, can you please repeat the age as a risk factor? What is the contribution of grade 4 disc?
It's not a grade 4 disc. It is an intervertebral disc. What I meant in my presentation. So all studies have found out that age is a major contributing factor for lumbar stress injuries. Athletes specifically in the age from 16 to 22 are extremely prone for lumbar stress injury. The primary reason they stay is that because the bones are still ossifying, the bones are still growing, and when there's a lot of load laid on that area, the bone's ability to absorb exceeds the external force laid. So that can lead to a lumbar stress injury. The other reason they say is in the younger population, the intervertebral discs are elastic and they're not as strong and as brittle as the adult intervertebral disc. As a result of this, a lot of forces are dissipated into the posterior vertebral arches, into the pedicle, into the lamina, into the pars. And when these forces are laid over a period of time, say for example, a fast bowler bowls 300 balls every week, and week after week, when that forces are laid, then in the long run, it can lead to a lumbar stress injury.
Next question. Why the healing time is more in a younger fast bowler than its older counterparts?
Yeah, again, that's what I said earlier, because the bones are still ossifying, the skeletal maturity is not obtained, and as a result of that, a younger bowler will take a longer time to recover. A bowler who is probably say 30 years of age.
How much the average time will generally takes for RTS after having?
Okay, so in the case of a pre-spondylolytic lumbar stress injury, where the clinicals are subclinical, where the signs are subclinical, and in the case of a lumbar stress injury, where there's bone marrow edema, there's no cortical breach, it can take anywhere from 2 to 3 months. Again, it depends on various other factors. Is there bone marrow edema only on one vertebra or on multiple levels? Is it one side or is it both sides? Is it the first instance or is it a recurrence? So all those factors need to be taken into account. In the cases of stress fracture, obviously the healing time will be more because there's a cortical breach. The athlete will be loaded for a longer period of time, and therefore the return to play will be delayed. It's tough to give an exact timeline, but if you're looking for a ballpark timeline, then for a stress reaction we are probably looking at 2 to 3 months. For a stress fracture we are looking at least 6 months, and it varies in cases of chronic non-united stress fractures, because you won't find any radiological support for that. You have to manage it symptomatically. So the time frame varies for various stages of that injury. Is it the first instance, or is it a relapse? Is it on one side? Is it on both the sides? Is it one level involved, or are there multiple levels involved? The age of the athlete, and all those factors are taken into consideration before we come to a conclusion on what possibly could be the timeline for return to play.
Next question, return to play for different state of pathology.
Yeah, that's what I spoke now, Kaushik.
How we train core muscle to prevent of any kind of injury?
I think core is extremely important because it's considered as the powerhouse of where your movements occur. So that proximal stability is extremely important. I mean, there's a lot of literature now showing that core doesn't help that much, but I think all athletes will agree to the fact that if their core is strong, they feel good about it, and it helps them to give that power generation. A lot of exercises are available. Pilates is taking the reformer. Pilates, lot of you can use the Swiss ball. Lot of equipments available to train the core, and I think you should make good use of it.
Is there any role biofeedback training in injury prevention?
Yes. you can use biofeedback in terms of core activation and stuff. We use the Chattanooga pressure biofeedback in terms of how long the athlete can hold that transversus abdominis contraction. But that is only useful in the early stages. We need to get to the athlete into the gym, get them strong, get them resilient, so that they are strong enough to take the load when bowling starts. Yes, it has a place, but I think we need to look at the bigger picture and get them stronger in the gym.
After injury, how much time we can put the bowler off cricket?
So again, that depends on what exactly it is. If it is a stress fracture, then obviously it's going to be out for a long time. If it is a stress reaction or a pre-spondylolytic stage, then they will probably get into playing a lot earlier than a stress fracture, provided they have completed the rehab program, they've got stronger, and there's enough radiological evidence for us that the injury has healed.
Is dry needling help to strain or stress injury?
I mean, yes, it is part of the treatment. Dry needling you can use, but doing it in the initial 4 weeks when the fracture site is still healing. I would use it in the probably in the subacute or on the chronic stage. If the athlete has got any sort of paraspinal stiffness or stiffness in his glutes or hip flexors, probably you can try and use dry needling as an adjunct treatment to all the treatments that we use. Yes, it can be used.
Yo-yo test range among male and female players.
So it varies from place to place. India, I think probably initially for the male cricketers we had at 16.1, and then we moved to 16.5. I think probably the benchmark will be increased in the near future. I'm not sure about the women's team benchmark. I can probably check and let you know on that.
Any app recommendations, sir?
For Workload. Yeah, I think there are a couple of good apps available on both iPhone and Play Store. I can probably WhatsApp that in the group. You guys can have a look. It's a very simple app which the players, the coaches, the physios, everyone can use it. Basically the player needs to feed on data every day, what the player has done in terms of how many bowled he's bowled, how he's feeling, how was his early morning stiffness, and all that information. Again, if there's a workload spike, all the people, all the stakeholders concerned would get a notification, and then the athlete can be managed in the best possible way.
Is that technique of back exercise same in wicketkeeper and pace bowler?
Not really, because in cases of wicket keepers, they'll be squatting a lot. So we ideally want to do a lot of hip hinging exercises with the wicket keeper. Whereas in the fast bowlers, they're going to involve a lot of extension, a lot of compound movements. So we will have different programs for strength and conditioning programs for wicket as well as for fast bowlers. Yes, the basic exercises are going to be the same, but when it comes to other compound exercises and those late stage exercises, there will be a difference in program.
Sir, you told it's criteria based in terms of recovery, not time based, but we need to specify approx time frame for recovery to the management and other stakeholder. Can you please explain it?
Yeah. So initially, when you take that call, you can give an approximate time frame in the sense that, say for example, you have someone with a stress reaction for the first time. This is his first reaction. It's at one level. It's on the non-bowling side. You can be reasonably sort of sure that okay, this is going to be fine in say 2 to 3 months time, and you give again you sort of give that report to your management. But having said that, if the player is just going to take rest in the house for 2 months, I don't think that injury will heal. So we need to make sure that the athlete is doing enough and is rehab, the athlete is doing enough in the gym, and the athlete is doing enough in his return to play criteria. So that is why it is extremely important that we give a time frame to the management, but at the same time we tell them that that time frame is applicable only if the athlete has fulfilled all the criteria that is required for him to return to play again.
Male versus female, more chances of stress fracture and
Yeah, unfortunately, female data has not been recorded that much in literature. I mean, it's a very unfortunate thing. Therefore, we are not in a position to sort of compare the prevalence and incidence of stress fractures in females. Hopefully, we can have more data over the years, and I think it will be a great data to have and interpret if there's any differences in incidence and prevalence of stress fractures in males as opposed to in females, and how the timelines and how the rate in both of them.
Increasing or decreasing run-up will help.
I mean, that is left up to the coaches. It depends on the bowler. So we are not sure about that. Obviously, if the bowler has a longer run up, it gives them then that momentum, and then the stress on the during the delivery stride can be relatively less. Whereas a bowler with a shorter run up, he will have to have a lot of forces going through his back during the delivery stride in an attempt for him to bowl quick. But I think these are all technical aspects. I think we should leave it to the coaches. They are the best judges of this.
Can you explain again Scottish toxin?
Yes, sure. I think I'll need to share the screen for that. Is that okay, or shall we do this question at the last?
Okay.
Yeah, you can finish off the questions, and I'll do this at the end.
What is the treatment protocol that helps player to recover faster?
Okay, so there's no recipe. As said, we can give you guidelines. So again, we need to respect the three stages: the healing phase, the loading phase, and the return to play phase. So in the healing phase, we try and offload the athlete. We avoid any extension. We avoid any quadrant movements. In the belief that will help the bone to heal, and that will prevent further aggravation of the injury. Once we are reasonably sure that the initial inflammation has settled down, then we get the athlete doing more activities in the gym. Try and start loading them axially in a gradual way. Start with body weight first, and then load them up, and do a lot of single leg stuff. Start a lot of compound exercises, and then the next step will be getting them onto the field, running, twisting, turning, and once everything is comfortable, then we get them into bowling again. Before that, they would be doing their bowling prehab. So it is a step by step process. It's difficult to give a recipe. We can give you guidelines, and based on what the injury is, based on what stage of the continuum the athlete is, we'll have to plan it accordingly. For example, the fracture healing time would be relatively less if it is a stress reaction as opposed to a stress fracture. So we need to take everything into account before sort of making those progressions.
Which action of the bowler more prone to lumbar injury, and what are the treatment on field?
On field, I don't think so. You can do anything. You can just manage them symptomatically. But again, as I said, this is not an acute injury. This is a gradual onset injury. Yes, you will have an acute on chronic presentation. So on field, we'll just have to manage them symptomatically, and then probably after the game is over, get thorough investigations done. Try and correlate it with this clinical presentation, and then take that call.
And same type question for sir, in your presentation, 4 different bowling action. So
Yeah.
which bowling action are good for the?
Yeah. So a side on or a side on or a front on action has a relatively less risk of a lumbar stress injury, because the shearing forces going on the lumbar spine is relatively less as opposed to a mixed action. There's no literature to support if a side on or a front on action can lead to a lumbar stress injury, but we have enough evidence to show us that a mixed action is a major predisposing factor for a lumbar stress injury. Although the MCC advocates a side on action because in terms of skill, I think it's a better action when compared to a front on action. The only thing we want to be careful is we want to identify bowlers who have that mixed action at a very young age. Try and speak to the bowling coaches and try and see if any modifications can be made at it. The earlier we do it, the better. Played for say about 8-10 years, and after that you don't want to make any changes into their bowling action, because then it's going to hamper their bowling, and then it's going to hamper their performance.
What are the exit criteria of each phase during different phases of rehab?
Yeah, so for each stage, as we had discussed, we want to make sure that clinically they're getting better. Say, for example, if someone had a pain provocation on doing a quadrant before, after 4 weeks, you check him, yes, the intensity of pain has dropped down. Are they getting clear radiologically? Are they able to do stuff in the gym in a better way than what they were before? Say, for someone 4 weeks back, he was struggling doing a single leg deadlifts. He's able to do that now. So all that are parameters that the athlete is progressing. So before we go on to the next stage, we want to make sure that one, he's clear clinically, he's clear radiologically, he's improving, he's doing more work, he's getting stronger, he's getting resilient in the gym. And once all these criteria are ticked, then we take them.
Is mobilization is indicated?
In the acute stage, no. I think we should just leave that spine. Just allow it active healing to happen. In the subacute stage, yes, we can do a lot of hip mobility and upper back mobility. Probably once we cross that subacute stage and once the athlete gets into that chronic stage, we can definitely mobilize the spine. But I wouldn't be mobilizing an acute stress fracture because that can hamper the healing process.
Is clinical assessment and MRI significant to diagnose it, or need to go further for CT scan for exact location?
Yeah, I think initially they would do an MRI. If they find a bone marrow edema at one site, then they would investigate that further with the CT. The problem with going for a CT initially is the radiations are extremely high, and we don't want the athlete to be subjected to unnecessary radiation. I mean, probably 15 years back, athletes used to go for a CT scan or a bone scan first, but because of the advancements, because of the advancements in MRI now, because of the quality of scanning, MRI is the preferred option now. And again, it's highly sensitive to identifying bone marrow edemas. So if you can identify that as early as possible, then it would be great.
Thank you. No question more.
Thanks, Kaushik. Any other questions? Yeah. So do you want me to?
I think before vote of thanks, we have to wait for most dynamic personality of IAP. Jasser is here. Just wait for 2 minutes for him.
No worries, ma'am. So Kaushik, in the meantime, can I go through those slides if it's okay? Because someone has, I think, asked about
yes, sir.
Couple of things, ma'am. One was the action, and the other, I'm not sure. Let me check. Let me share my screen. 1 second. Okay. So here we go. Okay. I think someone had asked about the bowling actions, right? Yeah, someone wanted to know about the bowling actions.
Yes, bowling action.
Yeah, okay. Sorry, I'll just get there.
Scottish
just taking
dog.
a little.
Scotty
Dog. Yeah, correct. Yeah, correct. So, so in the oblique view of an X-ray, we need to understand the Scotty dog appearance and the parts and try and correlate with it. So this is the lateral view of the MRI, a lumbar spine. Sorry, of the X-ray lumbar spine, and this is the oblique view. We can clearly see that in the oblique view, we are able to visualize the Scotty dog in a better way and try and correlate with the parts. So the nose is formed by the transverse process. The eye forms the pedicle. The ear forms the superior articulating facet. The neck, as you can see here, forms the pars interarticularis. The body forms the lamina. The inferior articulating process is by the front leg. The hind leg forms the inferior articulating process of the opposite side, and the tail forms the superior articulating process of the opposite side. So once we have an orientation to this, then I think it becomes easier to spot the fracture line on the X-ray. As you can see, X-ray, we can clearly see that this is the normal bone continuity, and you can clearly sort of find the discontinuity in the neck of the Scotty dog, which implies that there's a fracture to the pars interarticularis of this athlete. In terms of the bowling actions, I think this is just a basic idea we are having. There are a lot of factors involved, and I think the boarding coach will be in a better position to sort of make those technical changes. Okay, so if you look at the bowling actions, this figure here is a side-on bowling action where the back foot is parallel to the crease, and the contralateral shoulder is just behind. The head is just behind the contralateral shoulder or slightly outside of it. So when you come next to the front-on bowling action, you can clearly see the back foot is perpendicular to the crease, and the head is inside the contralateral upper body. Now, these two actions are relatively safe for a lumbar stress injury because there's not much shear forces happening. We need to look at the orientation of the shoulders and the pelvis. So if that angle is increased considerably, then the chances of getting a lumbar stress injury increases. So in the case of a mixed bowling action, so here it is a mixture of both the side-on as well as the open-chested action. So the upper body is an orientation of a side-on action, whereas the lower body has the orientation of an open-chested action. So again, in this, we can see the upper body has an orientation of an open-chested action, and the lower body has the orientation of a side-on action. So in both these, in both C and D, these are the mixed bowling actions because it's a mixture of side-on as well as open-chested actions. So in both these, the force vectors are going in opposite directions. As a result of this, there's a lot of shearing forces that is stressed on the lumbar spine, and when these forces happen over a period of time, they can lead to a lumbar stress injury. Is that okay, Kaushik?
Yeah.
Okay, cool.
Now I want to say something to Dr. Rishi Raj, CC IIP India. Can you, Rishi, can say something?
Good evening, everyone. First, would like to thank Kamlesh sir for conducting a webinar for IIP State West Bengal. Today topic is very different from other webinars. Hope everyone learned new techniques. और मैं आगे भी होप करूंगा कमलेश सर, आपने काफी अच्छे स्पोर्ट्स के एक्टिविटीज हमें बताए हैं कि क्या क्या किस प्लेयर को कब कैसे इंजुरीज होती हैं। और कमलेश सर के बारे में सभी कोई जानते हैं सर, 2012 से ही केकेआर के साथ है, और खासकर सर हमारा स्टेट ऐसा है सर कि केकेआर के साथ काफी जुड़ा हुआ है। तो मैं चाहूंगा सर कि आप अपना कुछ 1-2 मिनट अपने टीम के बारे में भी बताएं हमें सर, तो बेटर होगा सर। कमलेश सर।
I think it's been an absolute honor to be part of the Knight Riders team. I think the support we have received from the city of Calcutta has been unbelievable. Game after game, whether it's a weekday or a weekend, whether it's a 4 p.m. or an 8 p.m. game, Eden is always packed. I think the reception we received from the city of Calcutta when we won the IPL for the first time in 2012 was unbelievable. I mean, 70,000 people in Eden and another 1.5 lakh waiting outside the ground. I think it's a very emotional city. They love their cricket. People are amazing. I spend a lot of time. Probably Calcutta is my second home now. I spent in the last probably 12 years. I've been more in Calcutta than in Chennai. So I mean, it's great to be part of it, and I'm really happy. I was invited by the IIP West Bengal branch, and I hope I've done a decent job and try and created awareness about this lumbar stress injury, how we can prevent it, and because this is one of those injuries which happens in younger population, and if it is not looked into properly, then it can have long-term repercussions. A lot of players have actually gone on to lose their careers. So this is one conditions where we need to be extremely careful and sort of upgrade ourselves in this. Thanks Rishi, thanks Kaushik for having me here. Thank you so much.
So we have also sir our state secretary, Dr. Arindam Seth. Arindam.
Hello, good evening,
Arindam
sir. How are you?
Sir, you
Hello.
are not audible.
Unmute.
No, your
Okay.
voice is not audible, sir.
Arindam, please unmute.
I think he's unmuted.
Muted.
Sir, now you are mute.
Yeah. Now it's unmuted.
Sir, I think you have to remove your earplug and please then you have to speak. Sir, remove your earplug. Your voice is not audible.
Yeah, Dr. Arindam Seth, are you there?
Hello,
Maybe
doctor.
some technical fault is
Yeah.
there. Maybe he's not connected at that time.
Yes, sir, is here.
So I requested Kaushik Malik sir to say about Kamlesh sir.
Arindam, I think Arindam is connected now.
Okay, he's connected now. Okay.
Okay, I think
Dr. Kaushik.
Yeah, I am. Actually, many of the knows that Dr. Kamlesh is a BPD from SRM College of Physiotherapy, Chennai. Then he done his PG sports therapy from UK. And recently, last Chennai conference, he got an significant contribution award for the sports physio. Okay. And he's a physio for KKR for nearly 8 years. He done actually he's from Ranji team, Bengal Ranji team, East Zone team, India A team, India under 19 team for a couple of years. And Kamlesh, please, can you explain better?
Okay. So I completed my BPT from SRM College of Physiotherapy, Chennai. Then I went to UK to do my master's in sports. Then I got back to India. I worked for 1 year in a sports injury clinic. Then I got an opportunity to work with the Bengal Ranji Trophy team, where I worked with the senior team for 6 years. I've been in NCA for a couple of years now, where I got an opportunity to work with the India A and the India Under-19 team. I've been involved with KKR since the 2012 season. So, I mean, it's been a pretty good journey. The only thing is the time spent away from home, but it's all fine now. This is possibly the longest time I've been home since the last 12 years. So it's all been good.
Thank you, sir.
Thank you.
Okay. On behalf of IAP technical team, I would like to thank our today's chief guest, our IAP Women's Cell National Head, Dr. Ruchi ma'am, and also very thankful to IAP CEC East Zone Head, Dr. Rishi Raj sir. Thank you so much, sir, for your give valuable time and impactful this webinar. Even also we are thankful to our today's speaker, Dr. Kamlesh Jain sir, for giving such an informative session to us. Thank you so much, sir. Before end this session, I would also thank our IAP President Jha sir and our National Women's Cell Head Dr. Ruchi ma'am for providing us such a big platform. Thank you so much, sir and ma'am. And before the end of this session, I request to all participants, please subscribe our YouTube channel for watching live streaming and webinars. Thank you so much, all participants. Thank you so much, all guests, and thank you so much, speakers. Kamlesh Jain, sir. Thank you.
Thank you very much. Thank you.
Thank you.
Thank you,
Thank
Ruchi
you.
ma'am.
Thank you very much. Thank you.
Thank you.
Thank you so much.
Thank you.
Bye.
Bye. Bye.
It was wonderful webinar and wonderful lecture. Congratulations, IAP Bengal team. Arindam da, bye. Thank you.
Thank you, ma'am.
Kaushik sir, thank you.
Thank you,
Rishi
ma'am.
sir, thank you.
Thank you, ma'am.
Thank you, technical team IAP India. Thank you so much. Bye.
Bye-bye, ma'am.
Bye, ma'am. Bye, ma'am.
Bye.